So it gives me great pleasure to introduce Dr. Raggi. He's a professor of medicine at the University of Alberta in Edmonton and is a former director of the Mazankowski Alberta Heart Institute and chair of cardiac research at the University of Alberta. He received his MD degree summa cum laude from the University of Bologna in Bologna, Italy, and did his residency in internal medicine and cardiovascular diseases in New York City. He has been for some time doing a number of publications and has a lot of publications, over 300 in some of the major journals like New England Journal, Lancet, Archives of Internal Medicine, and the list goes on. And he is currently involved with a number of projects that include mechanisms of disease and atherosclerosis, vascular calcification. He's also trained multi-imager and actually one of the co-founders of the Society of Cardiac Computed Tomography. And it gives me great pleasure to introduce him today to talk to us about an interesting topic that's become more important nowadays about NOACs in chronic kidney disease. Paolo,
Thank you,
buongiorno.
Carlos. Buongiorno, ¿cómo estás, señor?
Muy bien.
Muy bien. Thank you for having me. I'm going to try and share my screen here in a moment. Hopefully this is it. Can you see the screen?
Yeah.
Do you see my slides? Yes.
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 There you go. Go to slide presentation. Looks perfect. Great.
So thank you, Carlos. Very generous introduction. I almost stumbled upon this particular topic because of my interest and long-standing interest in researching renal failure and the associated severe calcification of the cardiovascular system that accompanies advanced renal disease. I do not have any disclosure related to this particular topic. The only disclosure is that some of the studies that I will present at the very end have had me as a co-author or a mentor for those who have published them, and those who are sponsored by industry. I will disclose them as we get there. So, should we be choosing warfarin, or should we be choosing one of the direct anticoagulants as treatment for ischemic events in patients with advanced chronic kidney disease? You see here the big question: should I go right or should I go left? The reasons for choosing any of these anticoagulants is obviously to protect against stroke or ischemic events of other nature. But unfortunately, these medications are not free of side effects. And besides the bleeding, there are some upcoming new discoveries about the anticoagulant-related nephropathy that may follow the use of these particular drugs, and the potential to promote vascular calcification, and that's the topic of today's presentation. Years ago, I met this incredibly interesting investigator. Her name is Dr. De Vries, who lives and works in Bruges in Belgium. If you've never been there, it's a beautiful little city. And she is the one who got me interested in atrial fibrillation and the conundrum of anticoagulation. Do you know the legend of Shilla and Kiridi? This is a legend described by Homer, where the poor, oh my God, what's his name? The guy who was traveling through Mediterranean for years and years and years couldn't find his way home, and he had to go through this strait in Italy, between Sicily on one side and Calabria on the other side. And this particular channel is very famous for being extremely dangerous. If you get too close to the Sicilian coast, you get sucked into terrible currents. And if you go too close to the Calabrian coast, you just run ashore very easily. So which one of the two ailments do you choose? And that's the famous story told by Homer. Why do I think so? Because atrial fibrillation and DVTs are highly prevalent. The incidence is crazily high in patients with chronic kidney disease, especially in patients with hemodialysis, but also the consequences of using anticoagulants are extremely high. The bleeding complications are extremely elevated. So do we anticoagulate or do we not? These are the recommendations as they stand kind of nationally and internationally at the moment. As you can see here, below a creatinine clearance of 15 or renal replacement therapy, essentially none of the direct anticoagulants have an indication, except that they've been used outside of their prescription package. In the US, at least apixaban has, and rivaroxaban has been used in Europe or in a few places, as I will describe in a moment. Warfarin has an indication at any stage of chronic kidney disease, with the recommendation to maintain the time in therapeutic range over 70%, which is essentially almost impossible. I will show you in a moment some of the randomized trials that I've looked at, how often patients receiving warfarin are in therapeutic range, and it almost never happens to be that high. The other direct anticoagulants have a plus or minus indication for excuse me, chronic kidney disease down to 15 mLs of creatinine clearance, but essentially below that, none has been used classically. Truth is that in everyday practice, there is an increase in use of direct anticoagulants, both in advanced chronic kidney disease, as shown in this review article published in Journal American College of Cardiology, with a trend for more and more use for newer and newer drugs, as you can see here, both in chronic kidney disease and in dialysis, especially for apixaban that, as I showed you earlier, has an indication in the United States. As you can see, warfarin has been declining, the use of warfarin has been declining, and the use of direct anticoagulants has been increasing for the past 5 to 6 years. Just looking at some of the big anti-thrombotic trials that have been published in atrial fibrillation, the summary is that probably most of the direct anticoagulants, if not all, have the same anti-thrombotic activity as warfarin does, with probably fewer bleeding episodes. And that's for chronic kidney disease down to stage 3. None of these major atrial fibrillation trials enlisted or enrolled patients in dialysis. But if you look at the market, for example, the market review done in the United States in this REVAL study, if you look at the risk of stroke, the risk of ischemic and major bleeding, as well as intracranial stroke with rivaroxaban compared to warfarin, the trend is clearly in favor, or at least as good as warfarin for most of the events. Even though, these are patients with no chronic kidney disease down to dialysis. This is a sub-analysis of the ENGAGE atrial fibrillation, or TIMI-48, where edoxaban was used as one of the other direct anticoagulants. And again, no difference in both ischemic and bleeding events. So from the point of view of safety, they seem to be quite similar. This is real life experience, and I apologize for not reporting these references here, but there are references again back to some of the larger trials that have been published. And a few patients might have escaped on dialysis into these trials. And you can see again an equipoise between embolism and bleeding between the bigatran, apixaban, rivaroxaban, and warfarin. There are, however, a couple of meta-analyses that are fairly alarming. This is one that was published in patients with CKD 4 and 5 with exclusion of hemodialysis patients and peritoneal dialysis, and it's been published just a year ago, concluding that NOACs reduced the risk of stroke and systemic embolism similarly, but had a lower incidence of hemorrhagic stroke, although as far as venous thromboembolism or death, there was no conclusive evidence. And the limitation is that the evidence is very scant and mostly from subgroup or large trials. Our colleagues in Taiwan are much more pessimistic. This is an interesting research study, published very recently in the American Journal of Medicine, again in stages 4 or 5 chronic kidney disease. And their conclusions in 3,700 patients with atrial fibrillation and an estimated GFR of less than 30 was that essentially, yes, the NOACs at a similar risk of stroke and ischemic embolism has non-anticoagulated patients. So yeah, warfarin caused more ischemic strokes or was associated with more ischemic strokes, so not as good as NOACs, but NOACs were no better than no anticoagulation at all. And from the point of view of bleeding, both warfarin and NOACs were worse than actually no anticoagulation. The conclusion on our colleagues in Taiwan is that they prefer to not anticoagulate patients when they get down to CKD stage 4 or 5. That's quite a pessimistic view, I would think, but one that needs to be considered. What about warfarin itself? Is there any evidence that warfarin does any good for patients in stage renal disease? And again, if you look at ischemic stroke, hemorrhagic stroke, major bleeding, mortality, there's essentially no direct benefit of warfarin proven in any of the major trials or even in the meta-analytic studies. So what should we be doing? Should we continue to anticoagulate, and with what? Now, there's only one direct comparative study, not published, but released so far, that compared the effect of direct anticoagulation versus placebo in patients receiving hemodialysis. This is an actual randomized clinical trial. It's called the Renal AF trial, completed and presented at the American Heart Association, but really never published. This trial, as you can see here, randomized patients to apixaban versus warfarin in patients with atrial fibrillation on dialysis. It was an investigator-sponsored trial supported with a grant from BMS and Pfizer. The original study design aimed to randomize 760 patients to either apixaban 5 milligrams twice daily orally, or 2.5 if the patient had a very high risk of bleeding, versus warfarin with a target INR of 2.3, 2 to 3. And the major outcome was, primary outcome was major bleeding, clinically relevant bleeding. The reality is that the study was stopped early because of lack of resources. It was too difficult to recruit these patients. The recruitment was much slower than anticipated, and the enrollment had increased toward the end of the study, but the study is still underrepresented or underpowered. And in fact, instead of 760 patients, about 160 or 154 to be precise, were randomized. And you can see here that just a few came to the complete the study alive. Now, just to look at the patients enrolled, the CHAD score at baseline was fairly high, 4 for all these patients. Stroke had occurred in 15 to 20% of the patients prior to enrollment, and there was a pretty high prevalence of prior bleeding in these patients as well. Most of the patients received 5 milligrams twice a day of apixaban, 70%, and about 30% received 2.5 milligrams twice a day. Note, as I mentioned earlier, how often patients receiving warfarin were in target range, 44% of the times. So way under treated, if you will. And by the way, here in red, it says patients were 3 times more likely to be sub-therapeutic than supra-therapeutic with warfarin. Bottom line is the time to major or clinically relevant, no major bleeding was the same. There was no difference Now, please recall that this is probably an underpowered study. You may think that there is a signal here, but statistically there was no difference. These are all types and all the types of prior or major bleeding that occurred. If you look down the line here, there's no difference in incidence of any of these. And ischemic stroke was exactly the same between apixaban and warfarin. So the authors concluded that in this first randomized trial that was terminated prematurely with low power, most likely, there were similar rates of major and clinically relevant non-major bleeding. But a large proportion of warfarin patients were in subtherapeutic range, and who knows, maybe if they had been in more frequently in supratherapeutic or therapeutic range, they might have had even more bleedings. And they conclude that apixaban may be a reasonable anticoagulant choice in patients on hemodialysis. There's another problem with warfarin in dialysis. This new entity called anticoagulant-related nephropathy has been reported now in the literature several times, and it might have an impact on renal function over time. This is the typical renal finding of warfarin-related nephropathy with red cell casts both in the proximal and distal tubule, and also bleeding, massive bleeding within the glomerulus. These patients tend to have acute kidney injury, and it's a form of kidney injury that is not pre-announced by anything and not necessarily associated with supratherapeutic ranges of warfarin, so INR. And in fact, if you look at several meta-analyses or review articles, and you look in a forest plot at the probability of inducing or worsening renal failure in patients treated with NOACs, here to the left, or warfarin to the right, the trend is in favor of NOACs. In other words, they seem to be slowing progression of chronic kidney disease and reduce the probability of inducing acute kidney injury. This could be due to a lower probability of inducing a coagulation nephropathy, as I showed you earlier, or maybe also due to the lesser probability of inducing vascular calcification. More data of the same as I showed you a moment earlier. So what's the story with anticoagulants and vascular calcification? Vitamin K is absolutely necessary to convert or carboxylate some proteins that are very important for the function of the human body. Vitamin K dependent proteins are coagulation factors, as you see here, but also inhibitors of coagulation, matrix GLA protein, which I will describe in a moment, and growth arrest specific protein 6. The latter two are two very active anti-calcifying agents. They're very active in the fetal development and developmental times, and they are responsible for influencing calcification and decalcification of bone as bone grows. So, if we use warfarin to inhibit some of these epoxide and gamma carboxylase enzymes, we will induce the production of high levels of uncarboxylated proteins. Among them, uncarboxylated matrix GLA protein, which I will describe in a moment, may be a very dangerous thing to do. In the late 90s, Luo and his colleagues published this very seminal paper, and the disease from their investigation is also known as Luo's disease. In this experiment, they ablated the gene responsible for the production of matrix GLA protein in mice. This is the wild type mouse, and this is the ablated mouse. As you can see, the mice without a matrix GLA protein grows very, very slowly, is a failure to grow really, and dies quite young. Dies of what? Massive calcification. This is a very calcified cardiovascular system from the tip of their little noses to the end of their little tails, and they die of aneurysms of the aorta, as you see here, intracranial bleeds, and all sort of other cardiovascular untoward events. From that point on, it became an alarming concept that maybe when we use warfarin and inhibit the production of proteins such as matrix GLA protein, we may be promoting vascular calcification. There's also something worse that may be happening when we use inhibitors of vitamin K. As we inhibit the progression from glutamate to glutamate of several proteins, for example, activated factor 10, the inactive factor 10, or rather the activated factor 10 attached to a glutamide, a protein that is the outcome of use of vitamin K inhibitors. The complex of 10A and glutamide can activate PAR. PAR, of which there are 4 different types, are so-called protease-activated receptors. They're present on the surface of many cells in the human body, and they may induce cell proliferation, inflammation, cell migration, adhesion, apoptosis. If you're familiar with the basic science of atherosclerosis, all of these steps are necessary in promotion of atherosclerosis. If you instead did not block vitamin K and you let the factor 10A adhere onto a glutamate, not a glutamide, this activation of the PAR is inhibited. So one other good reason to use non-vitamin K dependent inhibitors of coagulation is to not stimulate protease-activated receptors. Is that all theoretical, or is that any evidence that any of this actually happens? And I'll show you some animal experiments and then human evidence that actually supports those concepts. So as far as animal studies, there's some biological plausibility in believing that vitamin K antagonists may promote calcification as well as atherosclerosis. In fact, vitamin K antagonists, as I said, inhibit matrix GLA protein and thus promote vascular calcification, and they have effect on PAR. No effect on PAR, or activation even of PAR, while the direct anticoagulants have no effect on matrix GLA protein and inhibit PAR. These are mice, ApoE negative mice. These are mice that are prone to develop early atherosclerosis, treated with warfarin for a few weeks. And you can see here the baseline matrix GLA protein control at 1 week, warfarin at 1 week, and then control at 4 weeks and warfarin at 4 weeks. And you can see from the baseline, the warfarin treated animals drop their carboxylated matrix GLA protein, as you would expect. On the other hand, the uncarboxylated matrix GLA protein increases. And look at what happens to the intimal media of the aorta of these animals. They slowly accumulate large amounts of calcification. So in an experimental setting, if you inhibit matrix GLA protein in animals, you may be promoting calcification of the aorta. Rivaroxaban instead has been shown to promote the reverse. This is WTD, stands for Western type diet for 14 weeks. Here is 6 weeks continuation of the same diet without any additional anticoagulant. And this is 14 weeks plus 6 weeks of rivaroxaban. And you can see that there's almost regression, or at least non-progression of atherosclerosis in animals treated with wild type diet, in other words, pro-atherosclerotic diet. And again, these are animals prone to early atherosclerosis development. Again, another experiment where this time not only the macroscopic sample is tested for atherosclerosis progression in animals treated with rivaroxaban, but in this case, PAR1 and PAR2 are measured. As you can see here, the macrophages decrease, the necrotic core decreases with the use of rivaroxaban, and PAR1 and PAR2 are inhibited. So it would appear that the direct anticoagulants may have an anti-inflammatory, anticoagulant, anti-atherosclerotic activity in animals. And, if you will, do not promote, like warfarin does, calcification. More experiments of the same type, so I'm just going to skip this because it's the same concept. What about clinical human data? Again, there's biological plausibility. There are animal studies to support that may happen. What do we have in the human sphere? Do we have any evidence of this? This is an observation, and T1, T2, T3 refers to how long patients received anticoagulation of a non-vitamin K antagonist type versus a vitamin K antagonist type. T1 meaning first tertile, second tertile, third tertile. You can see that using a comparative analysis type of study, where you compare patients that have received, just to give you an example, rivaroxaban for 1 year, 2 years, 3 years, there really is no major change in coronary artery calcification over time. If you look at patients that have received 1 year, 2 years, or 3 years of warfarin, and these as comparative, cross-sectional, please do not take this to mean that there is continuous progression, but in a comparative analysis, there's more calcification in patients who have received warfarin for a longer period of time. So there's and that pertains to vitamin K inhibition. What about vitamin K administration? If there is strong plausibility for vitamin K inhibition, what about administering vitamin K to both the general population and patients on dialysis? Because these are frequently vitamin K deficient due to poor nutrition, malabsorption, and gut microbiome changes. The problem is that we have no way, either in health or disease, to measure vitamin K levels. There's no direct testing in the laboratory for vitamin K. So how do we test the hypothesis that one type of hypothesis, I inhibit vitamin K and I cause damage. The other type of hypothesis is I provide vitamin K supplement and I improve health, both in general population and in dialysis. And how do I measure that? Well, there are a number of ongoing trials, as you can see here, and some have actually been completed and reported, where vitamin K supplements of one type or another have been used in postmenopausal women, in diabetes, in patients with CKD, etc. And you can see that the results here in the last column have been mixed. There's no firm 100% certain result that tells us that providing vitamin K supplements is really of benefit in the end. By the way, because we cannot measure vitamin K levels, the only thing we can do and that we can measure in the laboratory is to measure dephosphorylated, uncarboxylated matrix GLA protein. The higher the level of uncarboxylated matrix glyprotein, the lower the level of vitamin K in the system. Why am I wasting your time listening to all of this? Because I'm going to introduce you to a couple of randomized clinical trials that have looked at vitamin K supplementation and calcification. This is a small trial in the general population. You can see here, very small, 38 patients receiving vitamin K and 34 patients receiving placebo. Elderly patients with a fairly large amount of calcification. This is in the aortic annulus. And patients receiving vitamin K actually had a significant increase over time, decrease over time in aortic valve calcification. The placebo group actually had a small increase. So from this tiny, potentially underrepresented study, one could at least surmise or suggest that there may be a benefit in providing vitamin K supplementations. What about patients in hemodialysis? Do we have any evidence that vitamin K supplementation, with or without the use of direct anticoagulants, may help? This is an observational study. Again, please remember, this is observational and it's only cross-referenced study of 100 patients receiving a vitamin K antagonist for a long period of time and 250 patients receiving rivaroxaban for a long time. And for those who had no aortic calcification at baseline, patients receiving warfarin did tend to progress over time compared to patients receiving rivaroxaban. For those who had no aortic calcification at baseline, in follow-up, nobody receiving rivaroxaban had calcification of the aortic valve. You can see here for those who did have calcification of the aortic valve at baseline, a few progressed with warfarin, none progressed with rivaroxaban. Again, observational study, cross-comparative study. There are, however, a number of studies ongoing, and 3 have been published, where NOACs have been compared to warfarin, either alone or in combination with vitamin K, DOACs with vitamin K or alone. I'll just very quickly show you the first 2, these US trials, very small trials. The first one essentially comparing apixaban to warfarin in 66 patients with chronic kidney disease. And the conclusions were that there's greater volume progression of volume of atherosclerosis with warfarin compared to apixaban. The second trial was rivaroxaban versus warfarin in progression of coronary atherosclerosis. And that again, it's a very small trial with 97 patients, atrial fibrillation. And again, warfarin patients exhibited higher progression of total, non-calcified, and calcified plaque volume. Warfarin was associated with progression of total plaque volume in multivariate analyses. And those are direct comparisons of, direct comparisons of rivaroxaban, or direct anticoagulants with warfarin. The study, and I told you at the very beginning that I would reveal my contribution to this particular world of investigations. The study that I contributed to is this Bruges anticoagulation study. And Bruges has its own oral anticoagulation strategy in hemodialysis. It's obvious that stroke increases with increases SHAD, they say, but they also notice that history of stroke, diabetes, older age are significantly associated with subsequent stroke in hemodialysis, but curiously enough, not hypertension and heart failure, at least in their review. They published this review back in 2010. And in their hands, bleeding in hemodialysis is most strongly, the risk of bleeding is most strongly predicted by prior history of GI bleeding. keeping that in mind, they developed their own anticoagulation program. And this is what they do. They have their own scoring system where they give 2 points to patients with a prior TIA or ischemic stroke, 1 point to diabetes, 1 point to age over 75, and -1 to patients with prior intestinal bleeding. Now, if you had a prior stroke, you receive anticoagulation, or if you have an alternative, a score greater than 2, you receive anticoagulation. But if your score here is less than 2, you get no anticoagulation. This is in the hands of our colleagues in Bruges. What is anticoagulation in their hands? It's either vitamin K antagonists, apixaban 2.5 twice a day, or rivaroxaban 10 milligrams once a day. And I'll show you why they're using, especially rivaroxaban 10 milligrams once a day off-label. So with that in mind, they designed this study. They called the Valkyrie. My contribution here was that I was in the steering committee, and I was essentially taking care of the safety protocol in this study. This was an investigator-promoted trial supported only in part by the makers of rivaroxaban. So they screened 143 patients receiving dialysis, chronic dialysis, randomized 132 of those to 3 different arms. Vitamin K antagonists, as you would expect, with a predicted INR of 2 to 3, rivaroxaban 10 milligrams, or rivaroxaban plus vitamin K, again, trying to provide some help with vitamin K supplementation. Why did they use vitamin K 2,000 micrograms a week, 3 times a week? Because they did a dose searching study, and in the dose searching study, they found, or they concluded that 1,000 micrograms reduced the level of uncarboxylated matrix glycoprotein by 50%. In other words, it corrected the deficit by 50%. If 1,000 corrected 50%, they assumed 2,000 may be more powerful. So that's good. Let's use 2,000 micrograms. It's quite empirical, but at least they had some sort of study to look at how much vitamin K is needed in dialysis to correct the deficit. And why 10 milligrams of rivaroxaban? Because in their hands, when they did a dose searching study, the area under the curve with 10 milligrams of rivaroxaban provided exposure similar to 20 milligrams in healthy volunteers. So 10 milligrams in their hands in hemodialysis is similar to 20 milligrams in patients with normal renal function. So now you know why they randomized patients to vitamin K antagonists, 10 milligrams of rivaroxaban alone, or 10 milligrams of rivaroxaban plus 2,000 micrograms of vitamin K. These are the patients that were enrolled, quite old actually, for dialysis, but this is the age for dialysis in Europe. History stroke, fairly high. Gastrointestinal bleeding, also quite high. And a very high CHA2DS2-VASc score of almost 4.5 to 5. And also a very high Has-Blood score. These were serious patients. They were not easy early dialysis patients. They actually had a long history of dialysis. The calcification of the cardiovascular system in these patients is massive. You can see here the coronary arteries all outlined, and the vessels, by the way, and the valves. This is the mitral valve, the aortic valve, the aorta itself. Massive calcification of the cardiovascular system. What happened to those patients? Well, first of all, what happened to the uncarboxylated matrix glycoprotein? If you take patients who were warfarin naive on entry in the study, the uncarboxylated matrix glycoprotein went up exponentially, as expected, because that's the mechanism of action of the drug, while in the patients receiving rivaroxaban, it progressively decreased. This is also true for the patients who were not naive to vitamin K. If they continue to receive vitamin K antagonists, they continue to increase the level of uncarboxylated matrix GLA protein. And what about calcification? Here you see the progression of coronary artery assessed by Agatston score or by volume score in patients receiving vitamin K antagonists in green versus rivaroxaban plus or minus vitamin K. Vitamin K did not seem to have a major impact on the effect of rivaroxaban versus warfarin. There was a difference in trend, but it was not statistically significant because of the large confidence intervals. In my opinion, the study was underpowered to demonstrate the efficacy of one treatment over the other. As far as the aorta was concerned, the differences were even smaller than the coronary arteries. What about secondary efficacy outcome? Hemorrhagic strokes, there were only 2, and they were only in the group receiving vitamin K antagonists, none in the rivaroxaban treated patients. And as far as life-threatening or major bleeding, with the exception of the 2 intracranial bleeds, there was a statistically significantly lower incidence of major bleeds in patients receiving rivaroxaban plus or minus vitamin K. There are several other ongoing randomized clinical trials of vitamin K versus placebo, and these are patients that are all on dialysis. None of them have been published so far. All of these trials, as you might expect, are small. It's difficult to recruit patients in dialysis. They are difficult to manage. They have a very high mortality rate. Complication rate is extremely high. And it is unfortunate that it is also a little bit controversial what type of vitamin K supplementation should be used in what doses, and now to assess the effectiveness of the replacement. So I want to conclude by leaving you with this pessimistic, optimistic view that there are many contributing factors to vascular disease in chronic kidney failure. There are a number of agonists, in other words, factors that promote atherosclerosis and vascular calcification. Many of them I didn't even mention in this presentation, but there are several inhibitors that may actually favor the slowing of atherosclerosis and calcification progression, and some of them I discussed today. I hope I didn't make too much confusion in this presentation, but I'll be glad to take any questions from the audience. Thank you.
Thanks, Paolo. That was great. As they say, if you can't convince, confuse. So,
thank you.
So let me ask you something. I guess the main issue here is that there's a significant lack of evidence of what to do in this population. And there's 2 things. One is prevention of stroke and other embolism with the risk of bleeding. And the other is prevention of progression of calcification and atherosclerosis.
Right.
Now, you showed a lot of like surrogate markers. So all of these trials you showed in the penultimate slide, they're all going to be underpowered for major outcomes. So when are we going to see like a big trial looking into this? And the other question is, you know, why not use something like a COMPAS kind of association, low dose rivaroxaban with aspirin? Would that work in this population?
Yeah, you have a number of very important questions, and unfortunately I have no answers that make much sense. I can tell you that there have been other trials in the past that were very large that have used some intervention or another. We're talking about hemodialysis. I think that chronic kidney disease, as far as chronic kidney disease down to stage 4, is quite a different beast from hemodialysis. Once you enter hemodialysis, the cardiovascular risk is exponentially increased. There were 2 major trials in the past that used cardiovascular active drugs in patients on dialysis. And the statin trials, as you know, were negative in hemodialysis, but positive in chronic kidney disease. There was a trial that used sevelamer, which is an inhibitor of calcification as well, the DCORE trial. And that trial was trending in favor of the sevelamer drug, but it was not conclusively positive. There was another trial using cinacalcet, which is an inhibitor of calcification as well, also trending in favor, but not conclusively favoring calcification inhibition. You know, the reality is that patients on dialysis are a relatively small group. If you look at the United States, there are about 400,000 patients on dialysis. If you compare that to a population, the general population at risk of cardiovascular events, and how many we can study, for example, with atrial fibrillation, it's a minute fraction. So large clinical trials are unlikely to ever happen. And honestly, to put another little curveball into the answer, there isn't as much money in renal failure as there is in the general population, as much money to spend. So it's unlikely that we're going to have a definitive trial at any time soon looking at any of these interventions. Finally, Carlos, I think that the interventions have to be multi-dimensional. There isn't one single drug or one single intervention that will be effective. That's why I showed that complicated slide in the end, because I don't believe that there's one thing that can save people on dialysis. There are too many factors in contributing.
Yeah, I agree. We tried to do a trial in which we were randomizing patients to left atrial appendage occlusion device versus DOACs. And, we couldn't get it off the ground just because it was too hard to get these patients in the trial. So, yeah, there's a question here that if do you take into account the platelet count as a factor when prescribing DOACs in patients with CKD?
That's a good question. I do not know that we didn't do that in Bruges, but it's a good question. I don't know if there is a level below which there's a high risk of bleeding complications if you were to use DOACs. I don't think that there's anything in the package insert of any of these drugs.
Yeah, I don't think so.
Do you know, Carlos? I don't think so.
No, I don't think there's any level of platelet count which usually contraindicates the use of DOACs in any indication, but I don't know,
Right.
maybe
It makes particular sense in CKD because they do tend to have dysfunctional platelets.
Yeah.
Already, but no, I don't know of any special
Maybe with the safety
alarming
data that you have from Bruges, you can look into patients that were, I don't know if you looked at platelet count.
I remember that there were no signals, but I'm definitely going to go back and look now. Thank you for the question, Yusuf.
Okay, I see is Yorgo, Russell, Steve, Welton. Anybody has any questions? Yorgo is saying that Juarez was an RCT after MI that followed patient for 3,000 days. Warfarin arms had fewer subsequent MIs than ASA arm. How do you reconcile this with the pro-atherosclerotic data you shared?
RCT after MI that followed patients with 3,000 and warfarin and fewer subsequent MIs. Oh, I see. Well, warfarin is definitely a powerful anticoagulant. And I don't have any good explanation. That's why probably Compass was also effective, because it is an anticoagulant. And that's why we went to Compass, because of the great risk of bleeding in worst, isn't it? Or worst also. There's also a second question part to it. It says in meta-analysis that DOACs have not been associated with reduced MI rates compared to warfarin. How do you reconcile this with the data you shared? Those are good questions. I do not have a way to reconcile the meta-analysis with what I shared with you. What I shared with you are very small trials. They are animal proof of concept trial studies. The meta-analyses, as we well know, are helpful to get an indication for what's going on. They are not ever a final answer to any of the questions we have. I think that unless we do randomized clinical trials, as Carlos suggested a moment earlier, we would never have a final answer on any of these appropriate questions we have. The warfarin has a reduction in, yes, I know, I'm aware of the VARIS or WARIS trial and the reduction of MI. It was kind of an isolated trial, to be very honest, but the COMPASS, in my mind, actually is a better trial that shows that anticoagulation is effective in reducing MIs. So I think that if anything, you are suggesting that what I'm saying is correct, is not incorrect, that coagulation may matter in reducing myocardial infarctions, not just antiplatelet therapy.
Yeah, I guess that's still something to be debated there. And is it really, do they don't reduce MIs or they don't increase MIs? You know, I think that the overall data, when you look at it, is that there's really no untoward effect. As a matter of fact, there's an 11% reduction overall in mortality. So I've never known really what to do with that information. Anyways, any other questions? Apparently not. Well, yeah, this is a tough group to treat. So here are any patient relevant reported outcomes on DOAC versus warfarin. For example, pill burden, dietary restrictions, and are you aware of an economic analysis of a DOAC versus warfarin strategy in dialysis patients?
Oh, good question. No, to be very honest. I wonder if that could be done in sort of a retrospective way, but including all these trials, small studies that I've shown you. I suspect that if you have, in order for DOACs to be cost effective compared to warfarin, the incidence of bleeding should be quite a bit higher with warfarin, because obviously bleeding not only causes complications for the patients, but is also economically devastating for the system. So I don't know that we have enough evidence yet, enough numbers to run such an economic analysis. But hey, why don't we think of doing that? Actually, that's a very good question.
Yeah, well, we could ask some of our guys, you know, Glenn Sumner and other people that are doing some economic analysis. Maybe you guys can get together and do something.
Yep. Good question, David. Maybe you can lead the pack.
Okay, well, Paolo, doesn't sound like we have any other burning questions. Thank you very much for joining us today, and hope everything is good in Edmonton.
Thank you. Yeah, fairly stable and quiet here. Edmonton, you know that.
Yeah. Okay, well, thank you all, and we'll see you next week. Thanks, Paolo.
Bye to all my friends here. Bye-bye.
Okay, bye now.